Thank you for having me. So I'm going to present our research work looking at the effect of haemoglobin and red blood cell transfusion on gut perfusion and injury in preterm infants. So we all know in this room that necrotizing enterocolitis, or NEC, has significant consequences for our preterm babies, and the morbidity and mortality remains high despite advances in neonatal care. We know that ischemia, inflammation, and reperfusion underpin the pathophysiology of NEC. However, the association between anemia and/or red blood cell transfusion and NEC, despite being studied multiple times in the literature, remains controversial and remains incompletely understood. For example, some authors, such as Patel in 2016, proposed that it was actually severe anemia that increased the risk of NEC rather than transfusion, where there are multiple other authors that report a temporal relationship between necrotizing enterocolitis after a transfusion, with it occurring within 72 hours, and that's coined the term transfusion-related NEC. There's also a wealth of literature over the last 20 years looking at biomarkers of gut injury to try and identify one that could predict NEC, but so far that remains elusive, although intestinal fatty acid binding protein is the most promising. Near-infrared spectroscopy, or NIRS, is a non-invasive contemporaneous bedside management of regional oxygenation. And this potentially could be a non-invasive way of predicting gut injury by identifying changes in regional perfusion. The aim of our study is in blue there, and our primary objective was to investigate the association between haemoglobin and red blood cell transfusion with intestinal perfusion as measured by near-infrared spectroscopy and tissue injury as measured by multiple gut biomarkers. The primary outcome was a change in intestinal fatty acid binding protein in relation to anemia and post-red blood cell transfusion. And secondary outcomes were changes in all the other gut biomarkers we looked at and the NIRS measurements. We conducted a prospective observational study in our tertiary medical neonatal unit in London of preterm infants less than 30 weeks gestation. We monitored gut perfusion and injury weekly from birth until 36 weeks corrected gestational age or discharge. Because we're a level 3 unit, sometimes our babies were transferred to their local hospital before they reached 36 weeks. For these weekly measurements, we conducted 60 minutes of near-infrared spectroscopy, and we measured splanchnic tissue oxygenation index, STOI, and because we simultaneously measured peripheral arterial saturations, we also measured splanchnic fractional tissue oxygen extraction, SFTOE. In terms of the weekly gut biomarkers, we had weekly stool sample for calprotectin and weekly urine sample for intestinal fatty acid binding protein, IFAB, liver fatty acid binding protein, LFAB, and trefoil factor 3, TFF. We excluded infants with fetal growth restriction, abnormal Dopplers, or significant congenital malformations because they would place them at a higher risk of gut injury. And we measured the haemoglobin at the time of the NIRS measurements and categorized this into 3 groups, with group 3 of a haemoglobin of 12 or more grams per deciliter being considered normal. NIRS measurements and gut biomarkers were evaluated up to 72 hours before and after a blood cell transfusion. For the statistics, we use multi-level mixed effect linear regression models nested within each infant to account for the fact that measurements were taken over time and related to each infant. On the left, you can see an infant having the near-infrared spectroscopy done. This infant was having high frequency, and therefore the bandages are just to reduce artifact. The probes were placed just underneath the umbilicus. And on the right, you can see the monitor we use. We use the Nairo 300. And on the below right here is the data that we extracted using MATLAB. The second row up at the bottom is the STOI, and the fact that our line is very thin confirms that we had no artifact in our results. In terms of results, we recruited 48 infants, and our power calculation, we needed to have 43 infants to detect it at 90%. Our median birth weight was 883.5 grams, and our median birth weight was 26 plus 3 grams. And you can see from the range that we incorporated to the full range of infants from 23 to 30 weeks gestation. 52% were female, and the ethnic diversity reflected what we see in our tertiary unit. And the median number of weeks in the study was 7.3. In terms of the flowchart on the right, you can see there were several parents who we didn't approach because their baby was too ill and sadly they died in the first week of life, or because the parents actually declined consent for the study, as well as the exclusions. We therefore ensured that we looked at the differences in characteristics between infants recruited, infants approached and declined, versus the infants we didn't approach, to ensure that we weren't establishing a self-selecting group, and there were no significant differences. In terms of our results, for our primary objective in blue on the left table first, we found no significant difference in the level of intestinal fatty acid binding protein after a blood transfusion for all transfusions given over the study period, or for those given in the first 2 weeks of life, and we examined 195 discrete blood transfusion episodes. For our secondary outcomes for transfusions, we remain and found no significant difference for any of the biomarkers. In terms of anemia, for the primary outcome of intestinal fatty acid binding protein in blue, again, we found no significant difference when we compared to the baseline group that was normal in either that or any of the other gut biomarkers. We also separately analysed hemoglobin as a continuous valuable and as a discrete valuable for the lowest hemoglobin ever, and the results remained non-significant. When we moved for NIRS measurements, again, we found no significant difference in any of the NIRS measurements in relation to anemia, and also pre or post blood transfusion with 165 measurements. There are several strengths of our study. First, we're the first study that has looked at both hemoglobin and transfusion on both splanchnic oxygenation using near-infrared spectroscopy and multiple gut tissue biomarkers. I think it's important to say that the population we studied is representative of a tertiary medical NICU, and compared to the vast majority of previous studies looking at splanchnic NIRS and gut biomarkers, we had a much higher proportion of the extreme preterm infants, which are obviously the ones at the highest risk of NEC. We conducted a significant number of measurements, over 300 for urine and stool and 276 for near-infrared spectroscopy, and our longitudinal measurements went up to a median of 7 weeks, which is much longer than previous near-infrared studies because they had generally covered the acute transition period in the first 72 hours or the first couple of weeks of life. Our statistical analysis involved the help of a statistician, and also most authors have quoted a 10 to 15% motion artifact rate with NIRS, whereas we had 0. To acknowledge our limitations, not presented here, but there was a wide variation in the measured values of each of the gut biomarkers, and obviously that can affect the results. And also we acknowledge the timing of measurements in relation to the red blood cell transfusion. We chose 72 hours for practical reasons. It's difficult to get a urine or stool sample on demand. Also because of in the literature, transfusion-related NEC occurs within 72 hours, and studies have shown that IFAB remains elevated for at least 48 hours after gut injury. Allowing for the constraints of the times, I just wanted to highlight 4 topics for discussion. In terms of the regional oxygenation and effect with hemoglobin or transfusion, others do agree with us, and in similar studies involving preterm infants, found no correlation between regional oxygenation and hemoglobin. However, several authors report an improvement in regional oxygenation, notably cerebral, after a red blood cell transfusion, but this has only been studied in the vast majority of studies for 1 hour, 12 hours post-transfusion, and then up to 24 hours post-transfusion, so not as long as us. We did find a significant decrease in calprotectin levels in the first 2 weeks of life, and others have shown that calprotectin levels increase after a transfusion, which is probably what most of us expect, as it's an inflammatory mediated marker, and there is evidence to suggest that a transfusion would increase inflammation. However, the studies differ in terms of transfusion policies, and there are multiple confounders for calprotectin levels, including simple things as what type of enteral feed they're on, and also the number and course of antibiotics. We also know in the first 2 weeks, that's when that acute transition period is the highest, and intensive care interventions are their greatest. In terms of gut biomarkers and the association with hemoglobin and red blood cell transfusion, either the association just doesn't exist, or it's to do with our study design and weekly measurements were too infrequent. Animal studies have shown that in anemia there is raised IFAB levels. However, this has not been proven conclusively in human studies, and also the definition of anemia used varies. I just want to highlight at the end the ETNO and TOP trials, which I'm sure we're all aware of. And while I acknowledge they were underpowered to look at this specific outcome, they do give us some information on the effect of red blood cell transfusions on the rates of NEC. In both the liberal and transfusion groups, we know that the infants in the liberal group would receive more transfusions. However, they found no significant difference in NEC rates between the groups, which is either because that supports our theory that a transfusion doesn't increase the risk of NEC, Or is it that multiple transfusions prevent anemia occurring and therefore you don't get that ischemia reperfusion pathology? In conclusion, we found no association between anemia or transfusion with gut tissue injury measured by NIRS, by biomarkers, or perfusion measured by NIRS in preterm infants. However, to fully answer this debate about their involvement in NEC, further well-designed prospective studies are needed. Most importantly, standardizing the methods revolving around transfusion policies, the time interval between transfusing and the anemia, and also things as simple as the age of the transfused red cells. We need to look at those at greatest risk of NEC, including FGR infants and those micropremies. And we need to establish NIRS and gut biomarker normal ranges in extreme preterm infants if we ever want to be able to have cutoff values. I'd just like to acknowledge my colleagues, particularly on the neonatal unit, Bart's Charity, and also the families that informed this project. As you will hear shortly after me, Dr. Kerry Murphy is continuing this project in FGR infants as well. Thank you for listening, and I'd be happy to take any questions.
Thank you very much, Claire. An enormous amount of data presented there and clearly an enormous amount of work. I think we have a question from the floor already from Mark Johnson.
Thanks, that was really interesting. I'm Mark Johnson, Southampton. Could I ask how you derived your power calculation? Because 48 babies doesn't sound like very many, given that the thing you're measuring is a proxy for the thing you're interested in, and your thing your outcome measure is also a proxy for the thing you're interested in.
Yeah, and I think that's one of the challenges we had when we set up this project. And most people in this room will know that we lack robust study data for preterm infants to generate power calculations. So we used an adult study that was looking at changes in IFAB levels after a blood transfusion. They had 50 infants and 50 adults and 1 blood transfusion episode. And we therefore felt that the correlation would be higher in infants. And also, although our recruited infants was 48, we were looking at blood transfusion episodes that were 165. So in terms of the best guess that we could give for our power calculation, that's what we used. And bearing in mind, we had over 3 times the number of transfusions that this adult study based their results on, that's where we came up with that number.
Thanks.
Can I just ask how you accounted for variation in feeding, for example, and most units will also have add another question in there too. Most units will also have a tiered approach to transfusion where it's related not just to the hemoglobin level, but also to the kind of some proxy measure of the sickness of the infant, for example, whether they're ventilated or the amount of oxygen they're receiving. Were you able to account for that as well?
Yep. So fortunately, with the involvement of a statistician, because it was ridiculously complicated to enter all of that in, we looked at all of those as confounders. So things as simple as gestation, ethnicity, gender, but then also presence of PDA, enteral feed volume, type of the feed in terms of EBM, donor, or formula, and also whether they were ventilated into this linear regression model as well. And none of the confounders affected any of the results.
Okay, so very robust within the confines of the data that you've had. Thank you.
Yeah.
James Board. Oh, there's a question at the back. Sorry.
I've got the mic here, sorry. Helen Budge Nottingham and the Society's Treasurer. Thank you for your presentation. I'm going to take us back to power calculations. And you mentioned but you didn't present, unless I missed it, the variability in your data. So granted, there weren't studies for you in infants for you to base your power calculation on, but now you have your own data from this study. What was the power of your study?
I'm going to have to say that I don't know how to answer that, I'm afraid. I know that we used the statistician to come up with how we're looking through all the studies to base our original power calculation, but apologies for my ignorance. I will make sure I ask my collaborators how I would do that.
Yeah, so you can do a retrospective power calculation. And the reason I'm asking about that is because you didn't present, I don't think, the data with the variability, and we needed to see that in order to be able to interpret the number in the study.
Thank you.
Another question from John Dorling, please. Oh, James Boardman, sorry.
James first.
Yeah.
Thank you. James Boardman, Edinburgh. Thanks very much. Really clear presentation. Did you need to, and if so, did you control for jaundice in the NIRS measurements?
So we know that jaundice, for those of you less familiar with NERS, I'm sure most of you are, but the effect of the bilirubin and also the phototherapy itself can scatter the waveforms. None of the babies, when we conducted the NERS measurements, had phototherapy on, and we did look at the bilirubin levels, but actually none of the ones that we were examining, it was particularly high. And again, on the confounders, it didn't affect it.
Yes,
Have one.
please do.
I think you mentioned that there was 0% movement artifact, which is incredible, really. I think movement has been one of the things that's affected splanchnic NERS measurements over the years.
Yeah.
How did you achieve it? Because there must be something more than probe placement that delivered that, given that the babies are breathing.
Yeah, so we knew from doing our literature search before that motion intervalle as well as positioning was going to be our biggest problem for splanchnic NERS. So before we started the project, we did kind of test runs of measurements in well-term babies on our special care baby unit. And all of the probe excitement was only done by me. So it was in exactly the same place. There was me present for the entire time of the hours recording on every single baby, which meant as soon as there was any particular artifact that I can see, I can address it instantaneously. And we analysed in 5-minute epochs, and there was only 3 epochs, so 3 5-minute intervals where there was 10 seconds of artifact within our recordings. The other thing was that I timed the NERS where I would have minimal artifact. So, for example, we did them all at the onset of bolus feeds. We ensured the babies weren't due their routine cares at the time interval that the NERS was being done. None of the babies, fortunately, had any acute deterioration in terms of needing bagging or anything involvement from the staff during the NERS measurements. But we did pay real close attention to the artifacts and the fact that you're there for the whole time, you could address it instantaneously, rather than a lot of other studies, they've not had the person at the machine for the entire time.
Thank you. One final question, and then we must move back.
Hopefully quick. John Dorling, Southampton. So I'm just wondering if you could tell us a bit more about what the hypothesis was with what would happen with transfusions to the NERS, because NERS is gut oxygenation, I think.
Yeah, so it measures gut oxygenation, and then the SFTOE that you can calculate in relation to the saturations should give you an approximation of the balance of the metabolism, perfusion and delivery. So we hypothesized that anemia was going to cause a reduction in the splanchnic oxygenation. And then when you give the transfusion, which I think most of us, that's why we give a transfusion, because we want to improve end organ perfusion, we hypothesized that that would improve our splanchnic oxygenation. Based on what we know previously and from studies using cerebral oxygenation.